Good evening, aspirants. Good evening, ma'am. Ma'am, shall we start the session?
Yeah. I'm not. I'm just sharing my screen.
Sure, ma'am. So, good evening, all the aspirants. The topic for today is endocrine. It is a CBH session. Our speaker is Dr. Shraddha Patharkar, who is the associate at ABMH Pune. Thank you. Ma'am, you may take over.
We'll start with the case directly. So, 55-year-old male, 80 kgs, who stays alone. So, history couldn't be elicited. Brought to ER department in unconscious state by his neighbor. On examination at ER, he is hypothermic, heart rate of 50 per minute, BP of 90/60. Saturation is 80% on room air, so started on NRBM mask. He is E2 M3 B1, pupils were 3 briskly reacting to light, is barely arousable to DPS, deep painful stimulus. For airway protection, he got intubated, and the BSL was checked. It was 100 milligram per DL, and urine toxicology was sent. So ABG was done on NRBM mask. pH of 7.22, PO2 is 413, PaCO2 is 95, bicarb of 38, sodium is 125. What labs will you order to diagnose this case, and how will you manage this case?
Slide is not moving. The slide is not showing anything.
Uh, can you see these slides now? Because I'm
X-ray
sharing
only.
the
X-ray only is showing.
X-ray.
Yes, ma'am.
Yes. Now came. Yes, but make it in slide show button. Yes.
Yeah.
Yes.
Uh,
Okay.
Okay. Can you see now? Can you see this?
Still, it's in the edit button, not in the
ma'am,
slideshow.
put the screen in the slideshow mode. It is
Yeah,
near
ma'am. I've done
animation.
that only. Yeah. I've done that. Now again, I am exiting. This is escape.
Ma'am, I think that we are facing some technical issue. Actually, the screen is not visible in the slideshow mode in the session.
Yeah.
Ma'am, can you
To
again
me,
restate?
actually, to me, it's in the slide show mode only.
Okay, no problem. Can make zoom.
Can you see this now?
Yes, now clear. Better. بس decrease size. Yes, better.
So can you read the case now? Are you able to read this case?
Yes.
Yeah. So he is 55-year-old obese, staying on alone in. So history cannot be elicited. He he was brought unconscious by his neighbor, and at ER he is hypothermic, bradycardia, BP is on a lower side, saturation of 80% on room air, so NRBM was started. GCS is low, less than 8. Pupils were 3 briskly reacting to light, both barely arousable to DPS. For airway protection, he got intubated and the sugars were 100. Urine toxicology was sent. And this is the ABG. Can you read this ABG? What is the abnormality here?
Respiratory acidosis, metabolic compensatory metabolic alkalosis with
Hyponatremia.
and oxygenation seems fine.
Fine. Yes.
With
So
hyponatremia.
from the history, what can be the reason for his unconsciousness?
Mixed edema, comma.
What are the DD's differentials?
Uh, uh, Sorry to interrupt. Please, Dr. Anu, sir, please mute your mic.
Sorry. Can anybody tell me what are the differentials for this case from the history and the ABG?
Mixed
Mixed
edema,
edema, comma.
comma, hypothermia,
Okay.
hello,
Yeah.
acute intoxication, alcohol
Yes.
intoxication,
Very good. Yes.
Stroke, cerebral vascular accident.
Yeah, we don't know the history. It might be a known case of COPD also.
acute
But here the
exacerbation of
yeah, but the pH is compensated. So if it's a long standing, then this bicarb could have been higher. So even hypoglycemia. Anything else?
sugars are normal, ma'am.
Poisoning. Drug overdose.
Can it be seizure or any structural abnormality, brain structural abnormality?
Neuromuscular
Hyponatremia.
disease.
Though hyponatremia doesn't, this 125 of sodium will not cause this much of a problem, but if its baseline sodium, if at all, is 140 and suddenly it was brought down to 125 because of maybe beer potomania or something else. So you need to rule out both the structural and metabolic causes here, because we know this is the endocrine session, but in exams the case will be random. So you need to rule out metabolic common causes in this. Even for that matter, the starvation ketosis and alcoholic ketoacidosis. But again, it's not metabolic, so it can. You need to see whether it is a mixed disorder. So what labs will you order if this is a mixed edema coma?
T3, T4, TSH.
Okay.
In addition to the routine complete blood count, liver function test, kidney function test, procalcitonin, tropi,
Okay.
proBNP.
ACTH.
Even if the vignette shows AKI, then even serum CPK, because they do have proximal myopathies. So if AKI, that can be one of the differentials. Anything else? Because our next slide will be pertinent to that. Routine ECG, chest X-ray, all these things are also needed.
Urine, sodium, urine osmolality to rule
Yes,
out
yes,
hyponatremia.
yes. So what kind of a hyponatremia these patients have? Like euvolumic, hypovolumic?
Euvolemic hyponatremia.
Hypovolemic.
Yes. And in this patient, you need to do serum cortisol levels also, because associated adrenal insufficiency is also common. So our next, the how will you manage this case?
I will intubate this patient, ma'am.
Yes, you need to utter airway breathing circulation, ABC, for each and every case. Just
I will do manual inline stabilization, and I'm not sure about cervical spine also. Might be injured because the patient is unconscious.
yes,
So I
okay.
would like to intubate, first do suction and secure the airway with the help of a cuffed endotracheal tube. And then I will
Yes, this patient.
actively warm the patient.
Okay,
Put in 2 large bore IV cannula to give some fluids. Patient is hypotensive, maybe hypoperfused also because of hypoxemia. So I like to
but we need central warming. It's like the warmer should be towards the trunk, because already patient is
I
hypotensive.
will
Peripheral warming, it will
use targeted temperature control devices to
control uh, rewarming. You need to utter this word, control rewarming.
Acupuncture to the one.
And you need to start fluids because patient is hypotensive. Uh, these patients patient might have vomited. We don't know the history. So taking care of a blood pressure if needed, vasopressors, because again this he might be hypothyroid or he might be having underlying undiagnosed hypothyroidism. So we need to utter about all these investigations as well as the management. So thyroxine, what dose, and we don't know the history. So first we need to see chest X-ray and ECG if he's having, and 2D echo of course bedside we do, if this patient is having any underlying coronary artery disease, because we don't know the history. So the dose of thyroxine will be different in those with the coronary artery disease and those without coronary artery disease. But what will be the thyroxine dose otherwise in patients without any coronary artery disease in myxedema coma? Thyroxine dose? Anybody? Can you hear me?
400 Mike.
Okay. So near about 300 to 400 mic CS. More than 500 you should not go for, because it may precipitate arrhythmias and congestive heart failure. Particularly if coronary artery disease, then you have to start at a lower dose, 200 to 300 mics. And you need to continue such a high dose for next 2 to 3 days, but with a 50 to 100 mics taper. And on day 5, day 6, the dose should be 1.6 mics per kg. So it comes around 100 in 60 to 70 kg. So then again you have to supplement this with these patients with the hydrocortisone also. You need to control, take care of his blood sugars also. If needed, DNS we need to start. Then same patient on evaluation on chest X-ray. This is the picture. Comment on chest X-ray and how will you manage?
Pericardial effusion, money bag appearance of the heart.
Okay. Anything else? Bilateral CP angle blunting. So
Pleural effusion.
yes, chest X-ray is showing both the pleural effusion and the pericardial effusion. So this myxedema coma patients, uh, even in labs also you need to utter lipid profile, because these patients might have deranged lipids. How will you manage this case? Will you go for pericardial tapping?
According to the case, according
Yes,
to
if
the
the
condition.
yes,
If
if
it's
you will
affecting
do
the diastolic RV diastole, it's for urgent pericardiocentesis. If not affecting, it will be conservative, and then observation should be given for the patient.
yes.
Close observation.
So yes, if the patient is showing obstructive shock on 2D echo, or if there is a this Beck's triad, patient hemodynamically unstable, in all these cases only. Otherwise, if patient is a known hypothyroid, many a times this is a very gradual, the fluid gets accumulated gradually. So in such cases, we may not need to tap it. So again, you need to know the precipitating factors. Infections commonest hai. Then metabolic abnormalities, acidosis itself, even raised PCO2 can precipitate it. Cold temperature, various drugs, sedative, hypnotics, then burns, trauma. All of these are the precipitating factors. You need to know hypothermia management. Okay, that also you need to read thoroughly. Again, compensated and decompensated hypothyroidism. So when CNS is involved, it means this is a decompensated state. Then we call it as a coma. So we need to know the all the differentials of coma also. So, next case is 24-year-old female got admitted in hospital with generalized weakness, body ache, complaints of nausea, loss of appetite, and decreased body weight. She had low-grade fever also and 2 to 3 episodes of vomitings. She's hypotensive, 88 by 40, hypoglycemic, 70 milligram per dl. Labs done in ward suggestive of sodium of 128, potassium of 6.5, anemia. Urea is 58, creat of 1.8, and CBC showing mild leukocytosis and eosinophilia. ABG was done. It was pH of 7.24, bicarb of 16, PaCO2 30, chloride of 110, and sodium of 127. So, can anybody enumerate the important features, abnormalities in this case? And from this case, what you are suspecting? What are the differentials, and what is the provisional diagnosis? We'll go little
Ma'am,
quickly. Yeah.
this is a young female with presenting with non-specific complaints of nausea, body ache, loss of appetite, and vomiting. Patient is hypotensive and hypoglycemic. She is also hyponatremic and hyperkalemic. Possibly there is AKI also because of rising serum creatinine. And the ABG is showing metabolic acidosis with respiratory alkalosis and hyponatremia. So this picture is suggestive of acute adrenal insufficiency.
Which are the factors in favor of adrenal insufficiency?
Non-specific complaints, hypotension, hypoglycemia, hyponatremia, hyperkalemia.
Yes, so ABG is, if you read it carefully, it is showing NAGMA, normal anion gap metabolic acidosis. Many a times you don't get time to see for the compensations and delta anion gap, but look at the chloride. And when you look at the chloride and you calculate this chloride is high, hyperchloremia is there. And if the change in anion gap is lagging behind the change in bicarb, means bicarb is much lesser than the high anion gap, it means there is associated, this acidosis can be because of something else. If it is associated with hagma, then you have to suspect nagma. This is the case of normal anion gap metabolic acidosis, and because of the aldosterone deficiency that is associated with primary or secondary, with which this is more common, aldosterone deficiency. Whether it is common with primary adrenal insufficiency or secondary.
Second.
Primary is more common.
Because you need to, in my EDIC exam, we had this question. So in lab parameters, they'll give you, you need to differentiate between primary and secondary. So see, from the history, it can be sepsis also, because there is wide pulse pressure, there is mild leukocytosis, hypotension, hypoglycemia. So in differentials, you have to utter adrenal insufficiency is, because we know that this is endocrine case, but you have to utter commonest septic shock. Then you can utter adrenal insufficiency. Here the presentation is like acute abdomen. If there is a hagma plus nagma, then it can be DKA also. So all acute conditions, acute abdomen, that also in differentials you need to put. And AKI also, because AKI,
Starvation,
uremia,
ketoacidosis.
yes. So again, the primary adrenal insufficiency means when the primary cause is adrenals. When adrenals are at fault, there is a cortisol deficiency as well as the aldosterone deficiency, and that's why this electrolyte abnormality is very common in primary. That is the differentiating feature with the secondary. Secondary adrenal insufficiency means the problem is above the adrenals, either in the pituitary or hypothalamus. So aldosterone won't be a problem there. So that's why you need supplementation with fludrocort later on is needed in primary adrenal insufficiency. We'll see that later. They might show you this slide. This patient is hypotensive, and now clinical skin is showing all these changes. What you call it?
Hyperpigmentation.
Yes, very good. Hyperpigmentation again is a sign of primary adrenal insufficiency. We call it as Addison's disease. So again, in critical care, we'll get Addison's crisis, not stable chronic Addison's disease patients. But now the crisis might be they might be having underlying adrenal insufficiency, but they may have skipped their medications, steroid doses, fludrocort. They might have skipped it and now presented in Addisonian crisis, or it might be the first presentation, like in this case, young female presenting with hypotension, hypoglycemia, nagma, and electrolyte imbalances with discoloration. So again, this hyperpigmentation is primary adrenal insufficiency. It's not a part of secondary. So these are again differentiating features. So what is the management? Again, start with the ABC because they are having distributive shock. Start with fluids, resuscitate if needed, vasopressors. But the main important treatment here is
Steroid replacement.
Steroid,
yes. And how much you'll give?
200 milligram stat.
Yes, 100 to 200 mg stat, and then you give 200 to 300 mg a day for 2 to 3 days. And in primary adrenal insufficiency, you need to shift them on prednisolone later on. But hydrocort again provides fludrocort also. So that's why when we are giving IV hydrocort, no need to supplement them with the fludrocort. Once you shift these patients on prednisone, and even 50 mg of hydrocort is sufficient to provide fludrocort. But once you shift patient on prednisone, so the equivalent dose of your hydrocort gets reduced. It becomes 20. In that case, you need to supplement them with fludrocort 50 to 100 microgram. And again, treatment of the precipitating factor is very important. Even what are the precipitating factors for adrenal crisis? Can anybody tell me what are the precipitating factors?
Usually infection or stress,
Yes, very good.
operation.
Commonest is infection. Any stressors. So it might be decay can put patient into adrenal crisis. Any stressors like burns, trauma, surgery, even the minor surgeries, even if the patients, because it's a extra stress and patient is having underlying undiagnosed adrenal insufficiency, the cortisol levels will be inadequate in the body for that stressor, and they may land up into this. Even the extremes of temperature, that can lead to adrenal crisis. So you need to know the whole list of adrenal crisis. There are certain medications like etomidate can cause adrenal insufficiency, ketoconazole can cause. Uh, so autoimmune disorders, wherever the adrenals are affected. So it might be autoimmune disorder in India, where TB is very endemic. So tuberculosis, meningococcal septicemia. So you need to know all these infections, may viruses, TB, bacteria, any of these can cause.